Okay, you know the season. A patient comes in, fever, muscle aches, just feeling wiped out. Your first thought is probably a virus, right? But what if it's not? What if it's something a tick left behind? Knowing how to tell the difference is a huge deal for any clinician. And in this explainer, we are going to break it all down.
So let's start with a classic. A 34-year-old hiker from Connecticut, fever, myalgia, and a rash. This isn't just some board exam question. This is the kind of case that will walk into your clinic or your ER. So what's going through your head? What information is absolutely critical, and how are you going to use it to figure out what's going on? Let's dive in.
And here they are. Meet the culprits. Now, the most important thing to realize about these guys is just how tiny they are. We're talking about the nymph stages, which are often no bigger than a poppy seed. They frequently go completely unnoticed, and that's why they're behind most of the transmissions. It's also why so many of your patients will swear they've never even had a tick bite.
So here's our game plan. We're going to start with that first moment, the tick bite itself. Then we'll walk through the major clinical pictures, from the classic rashes to those tricky fevers without an obvious source. We'll wrap up with the must-know treatments and even take a peek at what's new and scary on the horizon.
All right, first up, you get that call or that urgent care visit from a patient who's just found a tick on them. They're worried. And this is our very first big decision point. Do we treat or do we wait? Now, this is so important. Not every tick bite needs antibiotics. In fact, most don't. For Lyme disease prophylaxis, the guidelines are super specific, and you have to hit every single one of these 4 criteria. It's got to be the right tick, attached for long enough, removed recently, and in a high-risk area. Why so strict? Because we really want to avoid unnecessary antibiotics. So unless all these boxes are checked, the right answer is simply to watch and wait. Okay, now let's get into the most famous tick-borne disease in the U.S., Lyme. Honestly, if you understand the different stages of Lyme, you've got a great framework for understanding everything else. The official numbers from the CDC say over 30,000 cases get reported each year. But listen, we all know that's the tip of the iceberg. The actual number of infections is probably closer to 10 times that. It's a massive public health problem. And geography is everything here. This map shows you the hotspots. If your patient lives in or traveled to one of these areas and they have symptoms that fit, well, Lyme disease needs to shoot to the top of your list. Your patient's zip code can be a huge diagnostic clue. Think of untreated Lyme disease as a story in 3 acts. Act 1, it's a local skin infection. If you don't treat it, it can move to Act 2, spreading through the body to mess with the heart or the nervous system. And then, months down the road, you can get to Act 3, a stubborn arthritis, usually in a big joint like the knee.
And here it is, the star of Act 1. The classic erythema migrans, or the bullseye rash. If you see this expanding, ring-like rash on a patient from an endemic area, that's it. It's a clinical diagnosis. You don't need to order blood tests, which are often still negative this early anyway. You just see it, you diagnose it, and you treat it, period.
But of course, it's never that simple, is it? Not every rash that looks like this is Lyme. Being able to tell the rashes apart is a critical skill, because one rash might be no big deal, while another could be a sign of a true medical emergency. So first, meet Lyme's doppelganger, starry, or southern tick-associated rash illness. It's linked to a different tick, the Lone Star tick, and it causes a rash that looks identical to Lyme. The big difference? Starry doesn't seem to cause any of those nasty long-term problems. But here's the clinical dilemma. You can't tell them apart just by looking, so the recommendation is to treat with doxycycline anyway, just to be safe. Okay, now this comparison is incredibly important. On the left, you've got that Lyme rash. Annoying, but treatable. On the right, that is the petechial rash of Rocky Mountain spotted fever. That is not an outpatient problem. That is a get this person admitted and treated right now kind of problem.
Rocky Mountain spotted fever, or RMSF, is the one you absolutely cannot afford to miss. Let's run through the clues. First, the timing is different. The fever comes first, and the rash shows up a few days later. Watch how it spreads. It starts out on the wrists and ankles and moves inward. And a huge clue is when it involves the palms and the soles. With a fatality rate of up to 10%, you cannot wait for a test. You treat on suspicion alone.
So what happens when there's no rash at all? Now things get really tricky. Your patient just has a high fever, chills, and body aches. This is where you have to start thinking about the other big tick-borne players. First up is babesiosis. It's actually a parasite, kind of like malaria, that gets into red blood cells. It's even carried by the same tick as Lyme. The way to diagnose it is to look at a blood smear.
You're hunting for these little ring shapes inside the red cells, and if you get really, really lucky, you might spot this beautiful Maltese cross pattern.
Now, for aereliosis and anaplasmosis, you're looking for a different clue inside a totally different cell. These little clusters are called morula, and they're basically clumps of bacteria hiding out inside a white blood cell. They can be tough to spot, but if you see one, that's your diagnosis while you're waiting on other tests.
Okay, this table is pure gold. This is your cheat sheet. The first clue is often on the CBC. For babesiosis, since it destroys red blood cells, you'll see signs of hemolytic anemia, but for early-osseosis and anaplasmosis, you're looking for low white blood cells and low platelets. We've talked about what you see under the microscope, but here's the most critical part. The treatments are totally different. Doxycycline is the go-to for early-osseosis and anaplasmosis, but it does absolutely nothing for babesiosis.
All right, let's bring it all together. What's the bottom line? When the pressure is on, what's your action plan? I mean, this quote really says it all. For the really dangerous stuff like RMSF, earliosis, and anaplasmosis, you cannot afford to wait for a lab test to come back positive. Delaying doxycycline is directly tied to people dying. Your clinical suspicion is what saves lives here. And finally, we have to remember that this whole field is constantly changing. The map of what ticks carry and where they are is being redrawn all the time. And here are just a few of the newer threats on the radar. Powassan virus can cause a brutal encephalitis. And look at Heartland and Bourbon viruses. They present just like earliosis with fever and low blood counts, but, and this is a huge but, they're viruses, so they don't respond to doxycycline at all. It's a great reminder to always think broadly and keep learning.
So that leaves us with this final question. When you've got all these diseases that look alike in patients from the same areas, what is the single most powerful tool you have in your diagnostic toolkit?
It's this. It's not a fancy test or a new imaging machine. It's your brain, a high index of suspicion. In the right time of year, with the right symptoms and geography, you just have to think about ticks. That's the first step. And honestly, it's the one that makes all the difference. Thanks for tuning into this explainer.